That brings us to the other important aspect of heart failure, that is heart failure with preserved ejection fraction. We know that 50% of the heart failure also with the ejection fraction of more than 40%. Now they call 40% to 49% what is called a mid-range ejection fraction. Even in that, or heart failure with ejection fraction more than 50%. So there basically, if ARNI has a role to play in those patients. Heart failure preserved ejection fraction will not be discussing, so it is quite common. Previous trials have failed. Previous drug trial have failed so far as heart failure preserved ejection fraction is concerned. In fact, the only drug that has come out recently is the SGLT2 inhibitors, both empagliflozin, now dapagliflozin, data presented yesterday, showing there is a significant benefit in the heart failure with preserved ejection fraction. Some observational studies showing is a similar clinical outcome with heart failure preserved ejection, reduced ejection fraction. But we discuss about an important trial, that is a PARAMOUNT trial. There is several improvements, several subdomains with ARNI in this PARAMOUNT trial. NT-proBNP was significantly reduced. This is a trial where sacubitril valsartan versus valsartan was done. So in comparison to valsartan, there is a significant improvement in NT-proBNP with sacubitril valsartan. Improvement in left atrial size was also seen with sacubitril valsartan comparison to valsartan. And NIH class improvement is also seen with sacubitril valsartan vis-a-vis valsartan. PARAGON heart failure trial that was in 2017. What it shows that this is a basically randomized double-blind active comparator trial testing the hypothesis that sacubitril valsartan compared with valsartan would reduce the composite outcome, total heart failure, hospitalization, and CV death. And these are the patients with LV ejection fraction of 45% or more. So basically, heart failure with preserved ejection fraction. So they are subjected to randomized to sacubitril valsartan 200 mg twice daily vis-a-vis valsartan 160 mg twice daily. The primary endpoint was composite of total fast and recurrent heart failure, hospitalization, and cardiovascular death. Secondary endpoint was improvement in NYHF functional classification at 8 months, changes in clinical, this KCCQ clinical summary score at 8 months, and then time to fast recurrence, occurrence of worsening of renal function, and time to all-cause mortality. Heart failure hospitalization, there is a reduction of around 15%. Cardiovascular death is also reduced. It's not reduced, but there is a reduction in heart failure hospitalization, though this is not statistically significant. Yes, CV death, there is no reduction. But there is significant heterogeneity so far as ejection fraction and sex is concerned, where there appears a beneficial effect is seen in females. So there the rate receives 0.73, suggesting there is a 27% lower risk of primary event if you are giving it to a female, and also with a particular subgroup of patients with a LV ejection fraction of less than 57, so there is improvement. So there is a 22% reduction that appears to be statistically significant so far as primary composite outcome is concerned. When you look at the EF quartile also, the beneficial effect is seen with 57%. So the ejection fraction cut off 57%. If somebody you have given sacubitril valsartan with the ejection fraction of less than 57%, then there appears to be that benefit. There is significant benefit so far as primary composite outcome is concerned. When you look at the total heart failure CV death by LV ejection fractions across ejection, means both PARAGON heart failure and PARADIGM heart failure data, there also you see if the HV, you look at there appears to be benefit across a particular group till you find that LV ejection fraction more than 60, possibly there is no benefit. till that time there appears to be some benefit when treating the patient with sacubitril valsartan vis-a-vis other comparator AS or R, and with ejection fraction up to 60%.